So varices, we're going to talk about EGD treatment. So how do you fix a varice, and also how do you fix a peptic ulcer disease bleed, right? So a peptic ulcer, that might be oozing, someone that might have gastritis and GERD, and that's oozing blood. Basically, this is going to be an upper GI bleed, and if it's brisk enough, it can cause a what? A bleed that is lower, right? So upper GI bleeds and lower GI bleeds can be due to upper GI bleeds, right? So the hematochezia can be an upper GI bleed, right? If it's melena, it's usually been in the GI tract for about 10 to 14 hours, and that's probably an upper GI bleed as well, right? So sometimes, rarely, it could be like maybe the right side. It might be a little oozing a little bit. Basically, you can do colonoscopies to look at the other side and for lower GI bleeds, and you do upper GI endoscopies or EGDs to look at a upper GI bleed of some sort, right? You can get all the way into the duodenum to see if there's an ulcer there in the duodenum, an ulcer there in the gastrum. You can see if there's variceal bleeds, like with liver cirrhosis, which is one of our most dangerous bleeds. And what we do is we either do clipping or we do banding, right? So clipping is for peptic ulcer disease. So that's where they go in there, just like with aneurysms, right? You clip them. So we just go in there and we just pinch off the vessel, pinch, pinch. So we got to see it oozing right there. We just grab it, right? And then we just pinch it with our endoscope. So you go in there and put a little clip on the arterial sides, vessels that might be oozing, and that will hopefully stop the bleed, right? So clippings are associated with PUD, and banding is with varices. So banding is just like this, where you take up all the varice and then you put a little necktie, or necktie, you put a necktie on your hair, a little hair tie on your hair, and that will then occlude the bleeding from getting worse, right? So here's the idea right here. So our endoscope goes in, and then they just literally have the bands ready to go right there they're all lined up, ready to go, and the band then gets placed around the varice or the varix, if you're talking about a singular varice, right? Varices is plural, varixes, right? So we're going to be placing these bands on the varices, and they did research about which one's better, and this one, of course, is the better one, right? So the band, they go ahead and suck up the venous globule of high pressure blood that's inside, and we'll throw a little hair tie around it, right? A little scrunchie around it to make sure that it's not going to ooze anymore, and that will make it ischemic at the base, and then hopefully it'll clot off and will prevent any further bleeding, right? So this right here is a what? What's this guy? This guy is a clip, right? And here is our band that we're doing. And they're looking for different targets when they're doing the endoscope. They're looking for, they know based on their training, they know what they should be looking for. They're looking for little white whales. That shows you that a varice is about to burst, or a varice that is under high pressure, right? Obviously, they'll see a varice that's bleeding, oozing and oozing and oozing. And they're going to go in there, target it, and try to put a band around it, right? So there they tied it off, and they were successful. Okay, so we have different signs, the red whale signs, little cherry red spots, little red stranding that they can see, and they can identify for a varice that might be bleeding, and then hopefully they can fix it, right? So we're not cauterizing, we're not doing things like this, we're clipping or we're banding, right? And which one is for ulcers? Ulcers for clipping, right? The chance of rebleeding is significant afterwards, so it depends on what they see. So like for peptic ulcer disease, for instance, if they see a nice clean base, the chance of rebleeding is very, very low. But if they see an ulcer that's oozing a lot, oozing, very, very high stage ulcer, then they have a chance of rebleeding. So that's why you stay in the hospital. This isn't like an outpatient procedure. They're going to get it done, and they're going to stay to see if they, depending on what they see on the EGD, they may have to stay a day or 2 days, right? And afterwards, we're doing serial H&Hs to trend the drop in hemoglobin, right? If we're oozing and oozing and oozing, we're going to see the hemoglobin start going down, right? So reserve for trends, and if the hemoglobin gets less than 7, that's our target. That's threshold for anemia. That's threshold for every blood transfusion is 7, right? There are exceptions, right? If they start bleeding profusely in front of you, we don't care what the hemoglobin is. We are going to transfuse, right? And sometimes it might say like 8+ for ACS. So if they have like a documented MI happening right now, we might just transfuse to 8, okay? Just like when we talk about SATs, right? If someone has a ACS or MI, we're 2 SATs of 92, 94%. Otherwise, everybody else has a what SAT? Everybody else in the hospital setting, 80 to 92%. Okay, so serial H&Hs, so we can transfuse if need be. So you might want to have some units on hold, so like 2 units of packed RBCs on hold. It's something to ask for after procedure, so that we have that ready to go just in case something were to happen. Okay, and then of course we're going to make sure that we are giving some therapies afterwards, some medical therapies. So we talked about last time about protonics, right, and histamine blockers. Which one's the better one? The stronger one is our PPIs, right? So PPI, BID is what we'll be starting. And sometimes you'll have some very, very conservative doctors who were trained in the past, and they were told to keep the MPO for a day at least, or maybe 2 days, right? So that has been completely disfounded or disbanded, right? No pun intended. But diet for the ulcer, for instance, for an ulcerative bleed, or basically within 1 hour, you can start doing clear liquids. Okay, 4 hours is regular diet, right? It depends on what they saw, right? They saw like a really oozing base, maybe clear liquid in 1 hour, right? But if they saw like a nice clean base, barely even bleeding at all, they can start a regular diet right away, right? There's no contraindications to this. As long as the sedation is worn off and they can protect their airway, they can start eating. Okay, they've probably been MPO for a while, just ahead of this piece. But again, just a note on MPO, do you need to be MPO for the EGD? No. If it's an emergent bleed, you can, you got to do MPO for 6 hours, and then we'll go ahead and let them bleed for 6 hours first, and then we'll go for procedure, right? So it's actually one of the linchpins about MPO. Like MPO is kind of like just a good idea. That was like expert opinion back in the 60s and 70s, but is there really evidence that it works? No, right? MPO for any procedure, it doesn't need to happen. You have a trained anesthesiologist, you have trained people in the room that know about this, about protecting someone's airway if it really got down to it. Okay, so it's just nice to have. It's not like an absolute evidence-based thing you should be doing, right? But definitely, if someone has a bleed in front of them, you're going to keep the MPO because we want to make sure they're like not eating like I don't know, Pepto-Bismol, or what else could they be eating? Something super sticky that you would eat, like okra. I don't know. Anyway, something super sticky, right? You don't want that all up against the ulcer. You want your ulcer to be bleeding nicely. I don't know. You want to be able to see a clean shot, right? Now, colonoscopy is different. Colonoscopy, you want to be able to see what's bleeding, or you want to be able to see a polyp. So that makes sense MPO-wise. They're not really MPO. They are getting bowel prep, right? And that's all they're eating. Okay, that doesn't have any calories, unfortunately. All right, so they will be hungry afterwards. And then about anticoagulants. So anticoagulants are going to be are usually important, right? If they have valve disease, if they have an MI history, or they have a stent placement in the past, we have to know when we can place them back on the therapy. Otherwise, they're going to have an MI, right? So we got to make sure that we are identifying who's at risk, and really up to 48 hours. That's really 1 to 7 days for sure, but 48 hours, 72 hours. That's really when we can start, starting their medications back on board, right? As long as the H&H is good for 24 hours, that's pretty much you're good to go. You can start your medications back up. Okay, so these are the ideas behind EGD treatment, right? We're looking for different things to band if they have what? Varices or ulcers? Varices. And if they have ulcers, we're looking to see what we can clip, right? See here, you got a whole bunch of clips. We got like 6 clips right there, right? And varices will get banded, and they'll say like band times 3. That means they have 3 different spots where they banded, right? They're not like putting like 3 rubber bands on the thing, right? They're finding all multiple varices. They're looking for specific targets that they can then band. Oozing, bleeding targets, of course, they're going to band, but also they're going to find ones that are just on the verge of bursting as well. Okay, so the idea here is you can see with a peptic ulcer disease, so here's a bleed, that's an ulcer, that's ulcerative. Ignore all my drawings there, right? But they see that oozing, looks like we might be at the top of the stomach, or like we went in and we're kind of looking up, right? So you can see that oozing peptic ulcer. What are they going to do to it? They're going to put a clip on it, right? So they're finding it, they're kind of find a good target, and then they will then deploy some clips. Okay, so that's an oozing peptic ulcer. And you can see here's the clipping that's being placed right here. So it's like this guy. So here they just attached the 2 clips already. They're washing it to make sure they captured the vessel, right? Did not. So we are going to apply some more clips there. So they have clip times 2, clip times 4. Okay, and they'll tell you they had a gastric ulcer or they had a duodenal ulcer. And of course, duodenal ulcer, they're going through the pylorus and into the duodenum, right? Because an upper GI bleed is defined as above the ligament of Treitz. And the ligament of Treitz is what's holding the duodenum, the distal duodenum. All right, and then we have a bleeding varix, right? That's just a one single varice. And what we're going to do to this one, we're going to apply a band, right? If we have a good target at least. So you see the speed at which a varix is bleeding? Right, that is a varice, and it is oozing like a hose that's turned on full blast, right? So this is why we say, should you transfuse these guys with 4 units of blood? All that blood is going to be oozing out just as fast as you give it. The priority for these patients is doing EGD, right? So you can go in there and band it immediately. And they'll say, oh no, that's optimizing for morning. Well, optimizing for morning, what does that mean? That might slow down a little bit, but if you give more fluids with the pressures low, that's all that fluid is going to go right to the portal circulation. It's going to ooze out at that speed, right? So it's not beneficial to wait. For peptic ulcer, you can wait. You can wait 12 hours or so. But for a bleeding varice, you cannot wait. As you can see, it is going to ooze out very, very quick. All right, so pre and post EGDs. This is specifically switching gears to variceal bleeds. We were talking about peptic ulcers and variceal bleeds and doing an EGD and what to do about it, but now we're talking about variceal bleeds specifically, right? And we'll talk more about varices just a little bit. We talk about cirrhosis and liver disease in one of our upcoming lectures, but here we're talking about what do you do for a variceal bleed pre-EGD. So before you go to the EGD and after the EGD, right? So pre-EGD, we do one more volume into that portal circulation that's going to be able to ooze as fast as it is. No, we want to vasoconstrict as much as possible. We're going to vasoconstrict the splanchnic circulation. Where's your splanchnic at? Or splanchnica? I don't know. Where's your splanchnic circulation? That's not just, well, spleen's included, but it's going to be your whole GI tract, right? So all the portal circulation is going to need to be vasoconstricted, okay? Because everything that you absorb from your meals, right? If we're postprandial right now, there's some cookies out, and you will be postprandial eventually. And these guys, once those cookies enter your gut, you're going to then absorb the cookies into your portal circulation, right? Whether it be your stomach, whether it be your esophagus doesn't really participate in digestion, but it's part of the portal circulation. And then your duodenum, your ileum, your jejunum, and then your large intestines and your rectum, right? All these things get filtered through the portal circulation, so it can be delivered to the liver, right? And when portal hypertension exists and cirrhosis and like ascariasis, when you drink freshwater parasites, all these things are going to cause increased portal circulation, right? Or increased portal pressure in there, and that's going to, your body's going to try to respond by releasing vasodilators, but they are going to not make its way up through the liver, and instead they're going to vasodilate locally, and now it's going to fill up with more volume, right? So our goal is not to give volume, but to do vasoconstrictors. And we have the GI hormone that is designed to shut everything down, shuts down the GI tract, it vasoconstricts the GI tract, it reduces secretions of the GI tract, including ulcerative properties like hydrochloric acid, and that'd be octreotide, right? So octreotide is given a little 50 bolus and then another 50 mics per hour usually, or it depends, but that's usually the drip that's being infused, right? So octreotide, and yeah, 50 mics an hour, sorry. So 50 mics an hour after the little bolus, and that's going to be our go-to agent, right? If someone has a variceal bleed. What if they just have an upper GI bleed, hematemesis? Do you know? No. So we're going to hit them up with sandostatin or octreotide right away, and then we're going to hit them up with pantoprazole as well, right? Just in case it's a bleeding peptic ulcer. We don't know. So we hit them with both. But if we know they have history of varices, they have history of cirrhosis, right? They have history of portal hypertension, they come in with huge ascites, you're like, well, shoot, that might be varices, right? So we're going to hit them up with some sandostatin or octreotide first off, right? And then antibiotics. Why antibiotics? How's that going to achieve hemostasis? Because bleeds are because of a leaky vessel, right? Vessels get leaky during infection. And they did research and they said ceftriaxone was what reduces mortality, reduces rebleeding risk. And it's going to be, the idea is that when you have a widespread infection or inflammation, That makes your vessels leaky, also makes you have hepatic encephalopathy, but these are also going to be used to reduce a variceal bleed, right? So the priority when someone has a GI bleed, especially if it's variceal, we're going to hit them up with antibiotics in addition to our vasoconstrictors. And notice the mnemonic here is variceal, right? So the third letter in variceal is R, and that's where we're going to resuscitate them. Aggressively? No, we're going to hit them up to hemoglobin of 7, right? And you want to have PRBCs on hold just in case they do start bleeding, but our priority is not to wait till morning again. Our priority is to get them an EGD as soon as possible, right? So if they're hemodynamically unstable, that needs to be a call to GI or call on the charge nurse to call GI or call the intensivist to call GI so we can get them fixed in the meantime, right? Because this variceal bleed, right, here's a big varices that's going to be easy to pop open and bleed, especially when they have an infectious process, right? And we might have to do a massive blood transfusion. And when you do massive blood transfusions, your hemoglobin is less than, yeah, maybe less than 7, but really, I misspoke. It's the systolic blood pressure is less than 90, and you have someone bleeding in front of you. How do you know they're bleeding in front of you? They have hematemesis, right? Or you have a lot of GI output, right? Or you have hematochezia, right? Hematochezia and varices, those don't combine, right? So we have to get GI in there as soon as possible. And in the meantime, while GI is arriving, that's when we can give the blood transfusions, right? So variceal bleed, right? You over-resuscitate, you give FFP, right, to restore the clotting factors because a liver patient usually has bad coags, right? Our job is not to fix the coags. Our job is to, unless they have anticoagulants, I should say, a little asterisk there, but our job is really to fix their variceal bleed, which is going to only be done by an EGD, right? All this extra volume, how much volume is in FFP? About how much? Same as the PRBC nowadays, about 300 to 350 cc's, right? That's going to be bled out as soon as you give it, right? If you saw what the rate of that flow was in that variceal bleed, it's going to be very, very fast, right? And that's going to dilate more of our vessels with the more volume that you put in there, and it's put more pressure in the portal circulation. But not only that, more volume is going to dilute out our clotting factors, and we need clotting factors to clot. So giving more volume with normal saline or even the better one LR, these are still going to cause increased amount of bleeding overall, right? And it's going to cause more and more dilution, more and more volume, and more bleed. And that's going to then we're going to say, oh, you could draw labs again. It's like, oh, look, the clotting factors are worse because you just diluted them with the volume you just gave them, right? And when we give more packed RBCs, these are warm packed RBCs or cold PRBCs. They're usually cold unless we're doing a massive transfusion with a low blood pressure. We might warm them up, but FFPs are also fresh frozen plasma, right? And when you have coldness in the body, that's going to make us more risk for coagulopathies, right? So we want to make sure that we are, warm them if we can. And after we give blood transfusions, we might consider intubating them, right? If they're throwing up all over the place, they are a risk for aspiration, especially if the systolic blood pressure is less than 90. They're at more risk of them getting more decreased ventilation, and they may need to be intubated for altered mental status. Also, PRBCs hold O2, and less O2 to the brain is going to make you more altered as well. As we mentioned, we're not correcting coagulopathies. If they have a coagulopathy, like they are on anticoagulants of some sort, yes, you will reverse those. But otherwise, your targets are going to be platelets greater than 50. Platelets are less than 50. Yes, you do want to transfuse platelets. Platelets don't really add volume. You can give platelets left and right. And then fibrinogen, really 120, 100 is usually go-to for liver disease and for a coagulopathy of some sort, right? Usually liver patients are pro-fibrinogenic, right? They have a lot of fibrinogen in their system, okay? They account for their clotting factors being reduced, right? So we're not going to reverse the INR, right? INR 2.4, 2.2, that's fine. We need to get them scoped immediately, right? We don't need to get the INR like under 1.8 before we'll do a procedure, right? We want to make sure they are getting scoped as soon as possible, and corrected coagulopathy beforehand is going to delay care, okay? So E, what's our priority is endoscopy, right? So upper EGD, so upper GI evaluation by a GI doc, right? So this is what gets a GI doctor out of bed in the middle of the night at 1 a.m. is to get them a patient with upper GI hemorrhage. That's why they're always on call for this exact reason, right? They say wait to AM, that's the wrong answer. That needs to be escalated up the chain of command so we can get them scoped as soon as possible, right? So door to scope within 12 hours, and what are we going to do on that? We're going to do a band or a clip? That's with a band, right? And then AL, we're really trying to stretch out this mnemonic, but A is alternative things, right? What can we do if endoscopy fails, right? As we mentioned before, if endoscopy fails, TIPS procedure is something that can be done, right? It's a TIPS is a someone who has failed their endoscopy. We maybe scoped them twice and they're still oozing, still bleeding. We need to reroute all that pressure through the liver with a transjugular intrahepatic portosystemic shunt, right? A TIPS to then take all that pressure from the portal circulation and bypass it into the systemic circulation, right? And also other alternatives would be a tamponade. We can place a balloon tamponade, right? Balloon tamponade is also an option, which we'll talk about on the next slide. And then lastly, once we are stabilized, then we'll do beta blockade, right? Obviously, if your patient is bleeding out, you're not going to be giving beta blockers, right? Patient's hypotensive, we wouldn't give beta blockers as well. But once they are fixed and blood pressure is stable, beta blockers are where it's at. That's where you want to keep them at, right? And also on discharge as well, so that we have improved portal hypertension. By improved, I mean the pressure go down a little bit, right? And we'll talk about this more when we look at liver cirrhosis and what the purpose of beta blockades are. But as you know, you have a liver here that is very, very cirrhotic, right? And you have blood vessels that are trying to drain into this liver, right? When you give beta blockade, what they do is they open up the liver, right? You have alpha receptors in the liver, right? When you have a alpha response or you have an SNS response, it binds the alpha receptors and it vasoconstricts them, right? So alpha receptors are also located on the liver. So if we give alpha blockers, right? We give beta blockers that are not broad spectrum but are non-specific beta blockers like propranolol or carvedilol. These guys are going to vasodilate the liver, and that will allow more fluid through, right? Reducing portal circulation or portal hypertension. So that's the idea behind this. Also, on the flip side, as we give vasodilators, the fluid goes to the periphery instead of into the portal circulation, right? So that's the idea behind giving beta blockers once someone is stable. Okay. So then post-EGD, what do you do post-EGD? So NG tube should be placed. Oftentimes the GI doctor leaves and says you're welcome, and then they took out your OG tube that you placed beforehand. It's like, hey, where'd that go, right? So you want to make sure they are placed in the NG tube or OG tube after the procedure, right? A lot of the doctors, they're worrisome that it will erode the stomach. That's like 14 days worth of an NG tube. It's not going to be happening in 1 to 3 days, right? So we want to have that there so we can detect when another bleed happens. Right, so when another bleed happens, then we can see that, oh shoot, we got to call you guys back in. I got 200 cc's out of my NG tube, right? Otherwise, they don't like us inserting it, especially if they just place the clips or the bands, right? Bands, clips especially, but they're like, oh, you're gonna dislodge my clips as you put your NG tube in. Is there documented cases of that? No, but it's a worry, right? It's like the clips are on there tight, right? Those aren't going to be dislodged by an NG tube unless you get looped in and you really, really aggressive. I don't know, right? So place endoscopy, or definitely within 2 to 3 days, because these patients are probably kept MPO, unfortunately, and their evidence again is 4 hours, and you start feeding them, right? So after 4 hours, after there's no bleed, H&H is stable, we can go ahead and do trickle feeds, right, to start giving them nutrition, especially if they're super sick on the ventilator, right? That's an idea. You want to get them better and off the ventilator. They're not going to do good if they are MPO the whole time, okay? It depends, but as we mentioned, if there was no complications, we got them extubated, we saved them, then clear liquid in 1 to 4 hours. Perfectly fine, right? Otherwise, if they're still tubed, we want to have the NG tube placed for us so we can detect it, right? And ideally, yeah, someone that's extubated NG tube is uncomfortable, but it can let us detect if there's bleeding. And then 24 hours later, it'd be safe to take out the NG tube. Then there's worry oh, my wrap around a band and take off the band. It's like, okay, all right, but so there's hesitation just in real life. Okay, and a regular diet in 4 hours, or soft at 24 and regular in 72 is usually what they kind of tend towards the older folks. Okay, so transfusion targets, we talk about this more in hematology as well. We can see if you do 7 versus 9, right? Some older practitioners might say transfusion of hemoglobin 8, just no matter what. but you imagine more PRBCs, given nationwide, is going to cause more complications. And in hematology, we'll talk about, PRBC transfusion reactions. But you just see here, there's 9% mortality compared to 5% with, giving blood. So it's important that we have a lower target, because if they have a higher target, more patients will die. So that's not good. So we want to make sure that we are transfusing to 7. And as we know with cirrhotic patients or portal hypertensive patients, they are going to have an increased risk of bleeding if we give more blood products to them. This is just general population. This wasn't like just cirrhosis patients, but we know it's documented that cirrhosis patients do worse when you give too much blood. So restrictive PRBC transfusions, right? What else? So you can see you got red whale, right? The red highlights there. That's what we're looking for on EGD, and they're going to go in there and they're going to band those targets, right? So you can think of them like Moby Varices. I don't know, Moby Dick. They're looking for these these white whales. Okay, is the target for our EGD intervention. So we got our beta blockers afterwards, right? They might do another EGD in 2 to 4 weeks to make sure that everything is good and copacetic. Okay, so EGD should be done within 12 hours, right? And they might need a TIPS done to if they are not able to get the bleed under control. They still are bleeding day 1, day 2 after the procedure, right? So HNH is still falling, and we're still seeing bloody aspirate out of the NG tube. So they may need to be transferred for a TIPS procedure, right? Or TIPS procedure done in-house, so we have a practitioner that does that. And then the other piece is, if we can't, we can do another strategy where we put a balloon tamponade in place. So we just put a balloon in it, and hopefully just put our finger on it for 24 hours, and hopefully that will fix it. Not your actual finger. No one has to be there for 24 hours. Put in a balloon that's going to put a lot of pressure on that varice or that bleed, and hopefully it will clot on its own as we give them antibiotics and reduce the amount of leakiness of our vessels. So Variceal tamponade. So you got these temporary devices for 24 hours where we put a huge balloon in their stomach and their esophagus, and that's going to occlude and tamponade the bleeding vessels, the bleeding varices. So we have 2 options. We've got a Minnesota tube and a Sang Steak and Blakemore, right? So that sounds like another insult, right? You Sang Steak and Blakemore, you just cut me off in traffic, right? So that's or an SPT tube. Not an SPT trial, but SPT, this guy is used to tamponade the vessels, right? And the SPT, the Blakemore tube, is the older one that came out in the 80s, 70s, I don't even know when, but it's been around for a while. The Minnesota is a newer one that's has a little more advantages, has an extra suction port for us, because we do want to be able to suction out the gastrum, because if their stomach is full of blood and we don't suction it out, what's going to happen? What will happen is mine, right? What will happen if that goes on? If you get more blood accumulated in the stomach, it'll raise their BUN because they'll digest it. But what else will happen? Is blood irritating? Yes, they will vomit, right? So we want to make sure their airway is protected. So usually these guys have an ET tube as well. Okay. So they have an ET tube as well. This guy, you never see someone with just a helmet on. And whenever you see someone with a helmet or you ask for the helmet, you think they're going to be putting a Blakemore tube in, right? And really the helmet is not necessary. That's just like for show. And it's really hard to put a helmet on and secure an ET tube and all these things. So it's not absolutely necessary. So as we come to find out, oftentimes they put the helmet in place and they're saying, and they're like, oh, then you're good. And they like secure it to the helmet. That was like the idea. But come to find out, you're not having tamponade if it's just secured right there. All this stuff is going to relax, and it's not going to be tamponading what it should be. If I have a bleed right in this area right here, I want this balloon inflated, and I want it compressing up against that gastrum, right? And that's what we're doing. We're applying tamponade or traction to this bleeding varice, right? So we apply about 1 kilogram worth of traction to the tube itself, right? And if we don't inflate the tube, it's coming right out, isn't it? Right? So that's just like you put a 1 kilogram of traction to an NG tube, it's gonna come out right away as soon as you put that kilogram of traction. So how do you prevent it from coming out? You have to inflate this gastric balloon, right? And you have to make sure the gastric balloon is actually in the gastrum. If you inflate this gastric balloon in the esophagus, that's going to cause some damage if you leave it there for a prolonged period of time, but also it's just going to come right out as well. right? So we want to make sure that this gastrum balloon is inflated. So we have 3 ports here at minimum. We got a port for our gastric balloon, we got a port for our esophageal balloon, and we have a port to suction out gastric contents. If we have an extra port for our esophageal contents, then we have a Minnesota tube, right? So that has a extra aspirate port. That's a Minnesota tube. But everything else is this SBT, or this Sangstein-Blakemore tube, right? So we are applying, applying suction, so we can pull out the extra gastric contents, but also the important piece for this whole device is applying tamponade, and that's done by applying how much traction? About 1 kilogram of traction. How do you get 1 kilogram of traction? You can find the 1 kilogram weight that we always have around, right? Where's that at? Was it? Where you pointing to? Where's you get 1 kilogram of weight at?
The pillows.
Pillows? No, pillows aren't about 1 kilo. Sandbags, if you can find a sandbag, but then the easiest thing is just to get a saline bag, because normal saline should be used for anything else but a 1 kilogram weight, right? Because 1 milliliter equals 1 gram, so 1 liter equals 1 kilogram, right? So just an NS bag we're attaching it to, and that's going to apply some traction. So 1 kilogram of traction that we're applying on this this Blakemore tube, right? And they'll do an X-ray. They'll inflate the gastric balloon. They take an X-ray to make sure it's in the right place. It's not in the esophagus, right? And then once it is inflated in the right place on X-ray, then you can use ultrasound too, but you're going to then apply the traction, right? And inflating the esophageal balloon next, which is done second after X-ray, that is kind of optional. They still are oozing, still are bleeding, then we'll inflate the esophageal balloon, right? If they truly have like esophageal varices that we really noticed. Okay, so that's the idea behind this Blakemore tube, is applying tamponade via traction, right? The balloon's inflated, so it doesn't go anywhere, and it's putting pressure against that gastric. If you put more than 1 kilogram of pressure, that's going to cause occlusion of those vessels and ischemia, which isn't good, right? So gastric balloon, and you never exceed about 15. Again, the gastric balloon, and never more than 45 millimeters mercury in the esophageal balloon. So you notice we were measuring pressures with this as well to make sure it's not getting too high. Otherwise, you can cause ischemia of the vessels. And now you had a variceal bleed, and now you have an ischemic bleed from the tissue that you made dead. All right, so that's the idea behind monitoring this tube, is to make sure that we have 1 kilogram of traction on it, make sure that we have good pressures in both balloons. Okay, so these are the steps that are detailed here. The helmet is not necessary, because oftentimes people will tape it to the helmet, and then how you apply traction. If you taped it right there, your securing point was on the helmet and not the 1 kilogram of traction which you needed. Okay, so what else to mention? This 1 kilogram of traction. More than the esophageal balloon shouldn't be inflated for more than 6 hours. It can start causing ischemia. And the other piece after this is we need to do the EGD in 24 hours. So if the GI doctor places this tube, then you ask him, okay, so what time tomorrow are you coming to do this? So you don't want them to be coming 2 days from now. That's going to put the patient more at risk for ischemia of the tissue from the tamponade. So it's usually a 24-hour maneuver that we're going to then hope it really is the last-ditch effort. You'll see these about like once a month, once every 2 months, where they're putting this tube in, and it's a last-ditch effort for someone that has a variceal bleed, to try to tamponade it and allow the body to get used to the antibiotics and hopefully slow down the bleed some bit, right? And also these patients you're adding on, of course we have the Sandostatin and Protonics, and we're adding pressors on, and of course we have serial H&Hs just in case the hemoglobin gets less than 7. Okay, so that's the idea behind this Blakemore tube. It is a temporary device.